So today I'll talk about hamstring injury. Start with anatomy lah. So hamstring consists of three muscles: the bicep femoris, semitendinosus, and semimembranosus. Bicep femoris got two head lah, long head and short head. So the long head originates from the ischial tuberosity, short head from the femoral shaft, and then they both inserts at the tibia lah, at the fibula head. And then for semimembranosus and semitendinosus, both originates from ischial tuberosity and inserts at the medial tibia. And then for the function, the hamstring helps in knee flexion and hip extension. And then bicep femoris actually helps in external rotation lah. And semimembranosus, semitendinosus also helps in the internal rotation of the hip. So for the definition and grading of hamstring injury is divided into three lah: grade 1, grade 2, and grade 3. Grade 1 is a mild injury, so it will be a slight disruption in the muscular tendinous area, and then for the pain part usually is mild pain lah, and then for function wise usually is mildly affected or not affected at all. And then for grade 2 is partial tear of the hamstring. So for functional wise, it will be slightly affected, and usually patient will complain of pain. And then grade 3 is a complete tear. Complete tear, usually they'll have a skin changes like ecchymosis or hematoma, and then functional wise will be a complete loss of function. And for the most common site of injury, usually is the bicep femoris. And then it depends on the mechanism of injury lah. So for those exercises which is of speed, sudden acceleration or deceleration, most common site will be bicep femoris. Whereas for those with eccentric lengthening of the hamstring will cause more injury to semimembranosus or semitendinosus. And for the risk factor, it can be divided into two: modifiable and non-modifiable risk factor. So for non-modifiable risk factor, usually when increasing of age, and then those who have previous hamstring injury lah, or those who have previous ankle injury as well. For modifiable risk factor, those athletes that increase intensity of training in a very short period of time, and then without a proper warming up before their exercises, weak hamstring, weak ankle, or and posture lah, like those with lumbar lordosis or pelvic tilt. And for history and mechanism of injury, history taking, usually patient will present with a sudden pain over the posterior thigh, and then they complain of a pop sound. Then subsequently, or mechanism wise, for high speed exercises lah, like sprinting, running, or for eccentric lengthening of hamstring, the mechanism usually will be knee extension and hip flexion, extreme. And then examination wise, we start with inspection. Patient's gait, look for any antalgic gait, and then look at the posterior side of the thigh, look for any skin changes, ecchymosis, hematoma. And then in long standing punya patient, looks for any muscle wasting or muscle atrophy. For palpation, palpate for any point of tenderness from the insertion and then the muscle belly, and then down to the from origin and then muscle belly and to the insertion. And then for strength, look for any loss of strength during knee flexion or hip extension. And then you can check for the contraction of the hamstring, put the knee at 90 degrees and then check for the strength. And then for the eccentric strength of the muscle, put the knee at 15 to 30 degree flexion. Then next, will be imaging. Usually ultrasound can see acute inflammatory fluid around the injury, like during acute phase. And then the gold standard is still MRI. Lastly, for the management, management refer to ortho usually if there's a grade 3 injury or any injury, even grade 2 that involve the proximal and the distal part of the hamstring, meaning at the muscular cutaneous junction. Then or any avulsion fracture, then we can refer to ortho. Otherwise, we can start with rehabilitation for post-injury recovery. So for rehab, usually in acute phase, they're divided into phase 1, 2, 3, 4 lah. So phase 1 is in acute injury, usually the first week after the injury. We follow the police protocol lah. So protection, and then optimal loading, ice compression, animation. So for protection, probably they can wear some tights and all, and then ice compression at the site of swelling, and then usually ask patient to rest for the first week. Then subsequently during the phase 2 and phase 3 part of the recovery, which is at week 2 until week 7 or 8, can start with optimal loading. So usually we follow the ASCLIN L protocol lah. Previously we had the ASCLIN C, but the study says that L protocol have a rapid, faster recovery lah, faster rehab. So ASCLIN L protocol consists of 3 different exercises, so 3 different functions. So the first one is the extender, which helps in flexibility, and then the second one is the diver that help in the hamstring strength and stability, and the third one is the glider, which put on an eccentric strengthening over the hamstring. And then at the end of it, at the phase 4, we will assess the patient again whether they are fit to return back to sports. So during the phase 4, we assess if patient able to do running or hip flexion, hip extension and knee flexion with resistance without any pain. We can allow them back to exercise lah in stages, meaning we slow run, jog, and then subsequently only adding the other exercises. So that's all for a short summary for hamstring.